Moving on now to the second sort of larger superordinate theme. The first one was a very persecutory nature of the culture. They're going to get you for this, was what one doctor was told when they made an error. There was a very profound sense of bullying by senior colleagues. One doctor described being subjected to a trumped up trial where the system seemed to want to target and exclude those who made mistakes from the profession. There was also a sense of people's personal information being weaponized. One doctor spoke about how their disability after a patient death was highlighted, and they faced significant intersectional discrimination, which involved gender, race, and disability. Second sub-theme in this theme was about being ignored and denied. I think I've touched on that. And this is one doctor who said, it was as if I wasn't there. There was a really quite profound prevalence of social ostracization and exclusion, from being ignored to not being included, to being sort of sidelined. Sent to Coventry is something that I always think about as a saying, that actually doctors were treated as if they weren't there. Through investigations, there was a lack of support, which exacerbated feelings of alienation. There was also, too, a sense of institutional silencing, that doctors reported feeling controlled and restricted because of the third victim aspect of the error or the event, whereby in some ways there was an attempt to contain the incident to avoid some of the broader implications. The final sub-theme in this theme is about how doctors attempted to find closure and integrate the mistake that had happened into practice. And this particular doctor here said, well, actually not having the issue was worse than having it. Not having it was, worse than having it. So what he was trying to say here was that he'd lived with the issue for so very long in their career that actually when it wasn't there, when it was finished, it was missed. So for some, they found it very difficult to get full closure. One particular doctor spoke about their relief and the freedom that when the coroner passed a verdict that they had nothing to answer to, it did allow them to move on, although they still obviously felt very sad about the death of the patient. Some chose to actually move away from medicine to heal, and to move away perhaps from the more acute side of medicine. This was seen as a shift that allowed them to perhaps regain a sense of control and purpose. But for some, the ongoing struggles with the stigma that was attached to them around their medical error, they never managed to move on from. And in this particular very sad case, references meant that lost opportunities for jobs happened in their future. And it just demonstrates how the consequences of being a second victim can sometimes linger indefinitely. The final superordinate theme was around leader support. And whilst there was excessive examples, I think, of negative leader report responses to the problem, there were also some examples of excellent practice. Briefly touching on some of the negative leader responses, a failure to actually resolve conflict resolution or to resolve conflict within disputes between doctors and their medical directors or clinical directors was identified as a problem. That some of the barriers to support got in the way of actually being able to help the doctor. That sometimes the unavailability or the unwillingness for the medical leader to become involved in helping the doctor or even just listening to them were key takeaways. And across all of these experiences, the leadership responses, as I said, were mostly inadequate. And these led to feelings of abandonment, isolation, and distress. But on the positive side, I heard examples of trust that really created proper, safe, reflective spaces for doctors to process and make sense of mistakes and opportunities to teach others in the wake of their learning. That was seen as particularly helpful by one doctor. But also, what I think restored another doctor's confidence was that despite earlier persecutory experiences from other leaders, one particular leader did affirm their confidence and worked with them to support their confidence in clinical practice and help them with their career progression. I think too that the medical leader who perhaps will offer emotional support and normalize the experience of losing a patient and sharing their own experiences was seen as really helpful. So some of the key takeaways from this superordinate theme is that whilst most second victims did experience neglect or negative responses, a few actually did demonstrate that the impact of supportive, compassionate leadership in helping doctors to navigate the emotional toll of adverse events was indeed very helpful. So the 4 findings that my research have offered the literature is that there is, unfortunately, a high psychological morbidity and suicide risk of the doctor who makes a mistake, notwithstanding the fact that there are also depressive symptoms, intrusive thoughts, but also a sense of entrapment and humiliation and defeat. And Rory O'Connor et al.'s research about what the factors are leading to suicidal ideation, I think, are particularly important here. I think it also shows that there is a need for additional support for doctors experiencing psychological illness post-adverse event, and this is emphasised. Secondly, there were high reported levels of psychological violence and social ostracisation. And I think this exclusion and incivility and abusive supervision were quite pervasive and certainly contributed towards doctors' feelings, particularly those who were left feeling invisible. Thirdly, without doubt, the impact of leadership is really important to think about here. Where there is unsupportive leadership, particularly in threats, in judgments, and in exclusion, this worsened the doctor's well-being. Incivility, unfortunately, appeared prevalent in these cases, and did contribute towards psychological safety, or rather, not being psychologically safe within teams, the doctor's self-esteem and team performance. And finally, the stigma and cultural challenges in medicine, it leaves very little room for psychological distress, with doctors feeling shame and guilt, feeling vulnerable, with mental health struggles, and sometimes not knowing where to go or what to say about that. The research too perhaps identified the stigma of being seen as the doctor who can't cope, and how this contributed towards internalized shame. And I suppose there's a double fallout here of both personal distress on one hand, but also the stigma of weakness that creates the additional barriers to not being able to seek help. So, just very briefly, because I know time is the essence, a few things that I would suggest that are great recommendations. Peer support programs. In my previous trust, we did establish a peer support program that I supported, but was also doctor-led. That was really helpful. But just being able to encourage open dialogue about psychological morbidity. We should speak more openly about psychological distress and train staff to be able to identify distress, burnout, lack of empathy, and take compassionate, intentional action. I think finally, too, my area of work when I was at the King's Fund was around collective leadership and compassionate cultures. Medical leaders of all levels must create cultures that support and learn from doctors, particularly in their darkest hour. And I think there is a role for leadership, which is critical in reducing suffering and fostering environments where both staff and patients can feel cared for and supported. And I feel this is really necessary. So I began saying that stigma around talking about mental well-being is very prevalent. I think that's the case not just for doctors, but for healthcare staff generally. And I wanted to leave you by knowing that there are pockets of really good practice, I think, in the system. But there are still some very difficult to hear accounts of people's experiences too. There's an opportunity, I think, in the research to look at particularly at what happens to those doctors who belong to sort of minority groups, and I think that perhaps is in my own research, looking back on it, I wish I'd looked more at ethnicity, sexual orientation, disability, and gender in my findings. And I think there's a really good opportunity to do more work in that area. I'm going to stop my slides now so I can see the rest of the room, but thank you for taking the time to listen to me this afternoon.
Thank you very much for that very interesting presentation and results as well, Donna. I'd invite people to ask any questions, either in the chat box or people who wish to kind of put their hand up and speak. I have a couple of questions, if you don't mind, just to kick off the discussion. The first one is, you spoke a little bit about some of the support that's available for doctors, particularly around peer support and the role of leadership. Are there any other proactive, reactive interventions or support that you think might be most useful in supporting doctors who have been experiencing trauma in the workplace, whether on a individual level or organizational level support? And my other question was, did you inquire about past history of non-work related trauma, or even repeated trauma in the workplace, and whether that might be a risk factor for doctors as well?
I think that I really want to go after the last question, but I'll answer those two in order. So there is support out there. Sometimes, if you can imagine that when you're at your most distressed, being able to have it signposted for you is really helpful. And I think that we do have a practitioner health program, which I think is excellent. I think there's some really good local, and I'm just thinking of that certainly in South London, there's a really good for GPs support function there. Sometimes what doctors really wanted was a peer with an ear. So they wanted to talk to their own they didn't want to be pathologized, or psychologized. That was really important to them. It goes to that sort of self-esteem and sense of dignity and identity. So I think sometimes where it was reported as being most useful, it was the senior or somebody who they perhaps perceived as just a bit further on in their journey, being able to listen to them. That felt really important. Your second point about past history, I do think there is something about previous trauma, and trauma is a very loose word.
Mm.
What constitutes trauma is different for all of us. Um, I think what's quite interesting, it's revealed particularly in two of the interviews an incidence of bullying as a young person, and I do wonder whether that there's something about what follows you in life, that if you have had an early experience of bullying, you might feel it when it
Mm.
happens in the workplace, which is quite different to those people who perhaps haven't. So I do think there is something about adverse childhood experiences that are a factor here, which I didn't look at.
Okay, thank you very much for that. Just picking up a couple of comments in the chat box. Someone's just inquiring about the generalizability of your findings to other worker groups of firefighters, for instance, or paramedics, so people who are working kind of outside of the hospital environment. Any
Yeah,
comments there?
I think, yeah, I think that looks as though that's from Kevin as well, isn't it? Yes,
Yeah.
I think so. Firefighters, so emergency services, firefighters, but I would also include teachers,
Mm.
who in the classroom are now dealing with things that are very different to what they might have done at the beginning of their career or early careers. Um, yeah, I would agree with that.
Okay. And I think the other point just to highlight also is the role of occupational health as well in
Mm.
supporting healthcare workers who experience trauma in the workplace, and the role of occupational health in that regard as well. I can't see any hands up. Does anyone have any questions I would like to ask?
There's a hand up here from
Is
Hi, it's
that
Magala.
Mangala.
Hello, Magla?
Hi.
Hi.
Thank you, Donna. That was great. I think, as with many things in medicine and science in general, it all seems like common sense, but actually we need the evidence. And so this is great. I can think of some other studies that may cross over, but not from the UK, as you say.
Mm.
You've obviously led us through your journey and you've landed at the recommendations. Did you get a feel for what might change and get us to the point of this being routine provision?
Well, I suppose listening to that question, I think what could change for the positive, but I think that certainly what has happened is the pandemic. What has happened is the acuity of presentation in patients and service users in all aspects of healthcare. And unfortunately, I think that we might have taken a retrospective step back rather than forward, because I think when I talk about being a peer with an ear, that takes time to listen. And I think that for many of you, you're really up against it. So my concern is that actually the situation could get worse before it gets better. That's not very positive, is it? But like I said,
Sometimes that's what we have to.
but I think sometimes it takes somebody that's not in the system to call it out, and I think that's what I would like to do, is to call out how difficult it can be to be able to be compassionate. When Michael and I looked at compassion in the work that we were doing around collective leadership, we know that for an individual to be compassionate to a patient, they need a compassionate manager. For that manager to be compassionate, they need compassion too. And then it all sort of sits at one very pointed area in an organization. So I think everybody needs compassion. And I think right now that's being really challenged.
Thank you.
I have a final question, really, and this is just going back to the issue around support. So we spoke a little bit about the role of peers and leaders, and also occupational health. So they're very much workplace support avenues. Where might someone go external to the workplace, do you think, to access support if people perhaps feel a bit more comfortable accessing support outside of work?
So there are provisions. Practitioner health program, I think, is great. It's regional. It's really, I think, from when I began this research, it was quite a small provision, but I think that's expanded. However, it is under threat. I think there are other third sector organisations that people can go to, and I suppose that for some people with adverse childhood experiences, there might also be a therapeutic route, and that might be helpful to people as well to work through past, certainly past experiences. I think that one of the great things about being in the health system is we do look after each other, despite what I've just said. Actually, that if one seeks help from the GP, I think the GP often takes things very, very seriously. And certainly the experience of some of the people that I spoke to had fantastic relationships with their general practice, their primary care provider. I was just going to pick up the occupational health, because occupational health can sometimes feel rather, if you're referred into OC health, you can feel rather done to, and that actually, that actually in going there, people often perceive that the manager is trying to, exit them from the workplace. That's a really difficult thing. But I think that most occupational health services that I've come across are really good, and they really will take seriously. I had lots of experience with occupational health provision during COVID, for long COVID, doctors with long COVID who I supported in my last trust. I can see in the chat, PHP is under threat. Yes, it is. Northern Ireland don't have a PHP at present. And that's why we facilitate and encourage self-referral, if they self-refer.
I think it also highlights some work that we need to do within the occupational health specialty ourselves, in terms of destigmatizing ourselves as a specialty, and that we are there to offer support to our colleagues across the NHS and other sectors as well.
I think so too.
Yeah. So we are just a few minutes past 1:15. So thank you once again for coming along and presenting your really interesting research this afternoon. Just to let the group know that next month we have 2 sessions planned, one on the 18th of February, where we have a presenter coming to talk about a scoping review project that we've been leading on last year with regard to the impact study. And also on the 25th of February, we have NIHR and the Colt Foundation will be coming along to showcase the range of different personal awards that are available to individuals who are interested in undertaking work and health research. And it'll be a really interesting opportunity for people to ask any questions that you may have with regard to these awards. And we will also be involving a member from a scientific committee who will be coming along just to talk a little bit about what they would expect to see in a high quality research application as well. So we hope all of you are able to join that session. So once again, thank you very much, and nice to see you all this afternoon.